So welcome to Symposium 3C, Considerations for Using Quantitative Ethnography in Healthcare. My name is Jamie Boisvenu. I am the sort of quasi-moderator facilitator for today's session. In a moment, I will introduce our panelists, but just to tell you a little bit about myself. So I'm an epidemiologist by training. I have my master's degree in epi, and I'm a health services chronic disease researcher. Right now, I'm doing my PhD in clinical epidemiology, and my subspecialty focuses on type 1 diabetes and lived experiences and how people interact with the healthcare system. Our other panelists this morning, we have Sylvie Zorgo, who is a medical anthropologist, assistant professor on unpaid leave at Semmelweis University, Budapest, Hungary. More recently, Sylvie has accepted and is currently fulfilling a Marie Curie Fellow at Maastricht University and completing her outgoing phase of the grant at Epistemic Analytics Lab at the University of Wisconsin-Madison. We also have Dr. Hee-Soo Zhang, who is an assistant professor of surgery at the University of Wisconsin School of Medicine and Public Health, where he is the director of surgical critical care services and the program director of the Surgical Critical Care Fellowship Training Program. Dr. Zhang's research focuses on reducing preventable errors in trauma care through the development of novel education and assessment methodologies. We also welcome Dr. Sarah Zhang, an assistant professor in the Department of Surgery at the University of Wisconsin-Madison, and her research focuses on developing learner-centered training environments and studying how perceptions of and experiences in those environments influence learning trajectories in the medical education field. We also welcome Dr. Andrew Ruiz, who is a health services and education researcher and historian of medicine at the University Wisconsin-Madison. His research focuses specifically on history of food, nutrition, and health, quantitative ethnography and digital humanities, as well as health services research and STEM and medical education. And we also welcome Abigail Woodridge, who is an assistant professor in the Department of Industrial and Enterprise Systems Engineering, where she directs the Human Factors in Socio-Technical Systems Laboratory, where her research focuses on human factors, ergonomics in healthcare, and health-related settings. And we do have another panelist who has not joined us today, but I will introduce him in case he is running a little bit late. We also welcome Vitaly Popov, Dr. Vitaly Popov, who is an assistant professor of learning health sciences. His research focuses on understanding, designing, and evaluating learning technologies and environments that foster collaborative problem solving, spatial reasoning, engineering, and design thinking. So today's session, I'm not sure if anybody had seen in the Slack, but I had posted some general initial thoughts about what we would talk about today. And if you had seen the conference proceedings, that may have also given you a little bit of an idea. But we have three areas of topic interest today to discuss, the first of which is using participatory QE in the healthcare space. This may include, involving patients and clinicians in the research process, either as partners or participants. And we are curious how you have used participatory QE or included patients in your own research in the process and what that was like for you. We want this session to be more of an open discussion. We really want to involve your perspectives and your worldviews in the conversation. So I will invite you to offer up your comments either in the chat, or if you would like to speak live as well, you can do that. And we'll open the session to our panelists as well in talking about this first topic. So does anybody want to sort of start the conversation?
Sure, I'll wait in. Why not? Yeah, so I think, at least from my perspective, in medicine at least, there's a really big difference between working with clinicians and working with patients. Part of that is it's a lot easier to get access to clinicians, but also, there's a lot of clinicians who work in a research capacity, and so it makes that collaboration really easy. So like, for example, like Sarah and I have done this for sure, and as have many others, I think, projects where if you're doing, medical education research, for example, you're often working with clinician instructors, with fellows, with, with residents, with other practitioners in that, in that work. Um, and it really helps because, like, at least for me personally, like, I'm not an MD, and so when it comes to the sort of technical content, like, not having those people involved would be next to impossible, right? And so it's sort of a necessary integration, and at least for my own research, like, I would love to get patients more involved, and most of the times when I've started to explore that possibility, it's been sort of structural problems more than anything else, right? Getting access to patients, and especially like patient representatives, like people who sort of work with researchers and represent patient perspectives are often in really high demand and often have very difficult. It can be often very difficult to get access to them because lots of researchers want to work with people in that respect. And so, at least in the few ways that I've done that, it's actually been really difficult to do. But I know others on this panel certainly have worked directly with patients, and that's been a different experience for them.
Yeah, it's challenging because there's a lot of, I think that there's an inherent power difference that exists between patients and clinicians that are participating in research. I am now just realizing that, participation in research doesn't stop when you ask people to contribute data to your study. And so I've really taken it seriously and included both patients and clinicians in my research from the start. And so these individuals who are participating as partners in this study that I'm doing are helping, design the objectives, the research question, deciding which methods are appropriate through a series of different conversations, and understanding what matters to them. Because, as researchers, we can come up with great ideas, but it doesn't really mean anything or matter if it doesn't matter to the people in which, you're looking to understand and study. So, I think my research specifically sort of takes it to the next level in the sense that we have people who are contributing their lived experiences about type 1 diabetes, but also people in our study team who have helped design that project. And it's really empowering, I think, as well. So we have, so I just posted our topic in the chat. So if any of you are interested in sharing that via text format, you're also free to open up your mic and share with the group as well if you would like. Does anyone else have any other thoughts on participatory QE?
I'll just go ahead and make a shameless plug. There is a symposia this afternoon about participatory QE. So if you're interested in thinking more about what that means and what we can do in a way that kind of more equitably values the EMIC and the EDIC, please do come. It should be fun. I'll be talking about borrowing a framework from participatory ergonomics and how that could help us kind of systematically describe participatory QE in that session.
Thanks for the explanation, Abigail. This is Nancy Wong. I wanted to actually ask if anyone, do excuse me because I've never really understood what is the meaning of participatory QE, but then I'm interested in looking at QE from the perspective of user-generated data. In this case, the voices of, I think, the patients as they are going through navigate different kind of treatment options and discussion among themselves rather than being elicited from, I think, an interviewer's or the researcher's point of view. And I wonder if anyone has had any experience in looking at that, as well as contrasting the kind of sort of ENA models that are generated from a clinical model versus a patient perspective model, and trying to see where that gap in understanding or experience may lie. So it's just something that I'm throwing out there.
Nancy, did you, the last thing that you said was that creating an EMIC model and an EDIC model separately? Is that what you were proposing?
Yeah.
Fascinating.
Because I guess a lot of the applications that I've seen from an ENA model standpoint is really contrasting the differences when it comes to a particular disease. I think, what I would be curious to see if anyone has had experience in contrasting, say, the clinician model of this particular sort of like disease versus the patient's perspective of the illness, and trying to identify where that gap might be. I think that could be informative.
I think that's a really interesting idea. And I haven't seen that done, but in my work, I've used to compare and contrast views of different stakeholders in the care team. So for example, physicians versus nurses. So I imagine the same sort of principle could be applied. But in the participatory QE symposia, we're talking a little bit more than just going to including the EMIC perspective from, say, the patient point of view. We're actually talking about how to involve them in the research process, whether that's kind of taking a participatory action-based research sort of view or community-based research sort of paradigm where they're actually members of the research team that identified the problem or the question that we need to answer, or be really involved in interpreting the data. Mike, I always forget Mike's last name, Phillips, has done some really interesting work looking at actually going and showing ENA networks to participants, and then based on their feedback, refining the network and the coding themselves. I don't want to speak on his behalf though, because I haven't done that, but I'll just say he's done it. And if you're interested in it, you should come.
Well, I think one of the things that's really interesting about this question too is that, so there's a lot of medicine that is really, especially recently, has pushed to sort of focus healthcare around caregivers and patients coming to a shared understanding, right? So all the shared decision-making work, all the sort of patient-oriented care and that kind of thing. The whole point is to try to take the sort of clinical expertise and the lived experience and find that kind of common ground or shared understanding so that patients are more involved in their own care, essentially, and the decision making. And so, one of the things that could be really interesting, and just for full disclosure, that's one of the things I'm really interested in. But it could be really interesting actually to look at those sorts of processes, right? Like how well do those things come together, sort of contrasted with, what I think is more what you're getting at, Nancy, in terms of like, there are lots of places where patients go and sort of self-support and interact and talk about like their own experiences and understandings. And if you looked at that sort of versus the sort of, places where clinicians do the same thing, you might see something really, really fascinating. And bringing those two strands together could be a really interesting place to sort of think about the ways in which clinicians and patients are able to kind of create shared understanding and the ways in which they're not still, or they're the places where there might be more struggles to do so.
Yeah, I think what I'm really motivated by is the fact that, oftentimes, I guess, clinicians, maybe because of their access to information and different set of considerations when they are perhaps recommending a certain type of treatments, and the patients are interpreting everything from their own perspectives that may not reflect the full understanding of what they are being asked to do and why they are being asked to follow a particular regimen. So I think it could be potentially really helpful to help them navigate that process and be able to as you said, to be more empowered to be, responsible for their own treatment in some ways. And so I just think that, yeah, this is something that fascinates me and what motivates me to come to these conversations. Yeah.
There's another dimension to that, Nancy, just piggybacking on that a little bit. You have the doctor's understanding, you have the patient's understanding, and then you have what the patient actually does. And that can differ, right? So it can differ vastly. So that I imagine could be some metadata that you collect, right? You can have a survey, although if you conduct a self-reported survey, you're kind of back to the same thing, but you can, find some ways of observing people and the behavior that they actually end up doing, regardless of what their thinking is about it, right? So I think that, yeah, go ahead, Jamie.
If I could just sort of build on what you're saying, Sylvie.
Yes, please.
Recognizing that healthcare is a very complex space. There's also, external environmental factors that influence how people living with a condition who seek out healthcare interact with the healthcare system, how they manage their own care, and even just how those conversations with clinicians go is largely dictated on those external factors. Health insurance is a good example of how it can steer those conversations. We really would like you to use this type of therapy to manage your disease. And I mean, it's easy for somebody to say yes who has health insurance to do that. But it's not always, we don't always have that choice. Are there any clinicians in this room that would also like to weigh in, a clinician perspective, perhaps?
Yeah, I mean, I think this is just an absolutely fascinating idea. I think there'd be two sort of, I like this idea of having, different models of interpreting your ENA graphs and sort of being able that that two people may look at the same data and, come up with different interpretations, which in this day and age seems like it would be sort of obvious, but it's very, now having somebody say that to me, it makes, great sense. I think one of the challenges of doing that type of research where you're trying to see the differences between the clinicians and sort of the patients is that, the clinician cognitive process is not always reflected in the conversations that you have with the patients. And so I think the biggest challenge would be finding a way to get some of that rich aggregate data that you can then interpret and really model out how a physician or nurse practitioner, how they think about a specific problem. And because oftentimes the conversation that we have with our patients doesn't necessarily lay everything out in terms of our decision making. Sometimes it's hidden behind intentions and things that we'd like to move the conversation forward, especially in this day and age of having external influences and external pressures to shorten our visits and to make things more efficient. So the partnership would have to, I think, you may be able to pull some of that out between the physician-patient interaction, like in many other places, but you may need a sort of another level of data gathering, I think, to get to that area where you're thinking about shared decision making and how you could sort of overlap and figure out where people are discongruent.
This is really fascinating, Hisu, and it actually raises a question I've never thought of before, but that you would be well placed to answer is, this idea, right, that like you have sort of a cognitive model that you're bringing to an interaction, but you're not necessarily laying it all out for the patient in any particular case. Do your case notes, when you're writing up those say consultations or whatever the clinical interaction is, does that tend to reflect more the sort of your sort of primary cognitive model there? Are you writing up more what a description of the conversation was like? Because I've actually never really looked at case notes that much, not modern ones anyway, and that could be an interesting comparison as well.
So, I mean, I think they're two different outputs, right? I think, and they're not always the same. I would think that sometimes physicians think they're telling patients things, but if you actually went back and recorded them, I would bet that a lot of times they're not saying a lot of things that they're putting down. I think that I think notes are imperfect, and I think the patient conversation is imperfect, but like in anything, I think as long as you have multiple sources looking at, from different perspectives of the sort of the decision-making process, I think you get a more clearer, more descriptive picture. So I would say that like the notes tend to be more descriptive as the stakes get higher and the case gets more complex. And so that I think it would depend on the gravity of the conversation or the stakes of the conversation that would determine how good that input quality was. I don't know that that's how we should practice medicine, but that's probably just how medicine is practiced.
Well, right, and that's what we're all about, is trying to understand the realities of it, right? Not the ideal. But I mean, this conversation is really interesting because it's making me think much more deeply about sort of the potentially archaeological nature of the kinds of stuff that we're trying to do, where we actually, I mean, it can be very hard to get access to some of these types of sources, but we actually could potentially access a lot of different types of information, right? There's, the recording or transcript of the conversations, there's the clinical notes, there's the actual like clinical outcomes, there's, things like internet fora where patients go and share stories or support one another. There's potentially like a wide range of different source types that could all sort of point to different aspects of a problem. And I don't know, I think most of us, it's so hard just to get access to one of those things that like, that we tend to focus on, the thing that we can actually get access to. But it could be really fascinating to figure out how to actually bring all these things into conversation. And Abby, I think you've probably done the most in terms of being able to integrate like different pieces, but I know like for all of us, it's just so hard, it's so challenging to get that data.
Yeah, like here in Alberta, you don't even getting access to footnotes in the EMR is just not even a thing. It's not available to researchers. It's a no zone. And there's so much rich information in there that we could look at in terms of quantitative ethnography that it's just goes off into the ether.
I'm motivated by some of the work that I've seen being done using ENA models on, I think, just existing literature, whether it is from medical journals about treatments of maybe, let's say, type 1, type 2 diabetes, for example. And so I guess, can we actually use that kind of data to construct what the prescribed medical model or clinical model should look like without necessarily having to access physicians' notes, and to compare that to how these online forums, when people or patients coping with that conditions and their understanding of it. And I think it would just be an interesting contrast between these two, what should be prescriptive versus what is actually being practiced.
I kind of like this idea of like looking at sort of like online communities and things like that. I mean, I think in the US, it's a little bit easier to get access to patient data. But I think one of the things is that you have to frame it in a way that makes sense for the healthcare system and the healthcare community at large to buy in, right? And so, and the way that a lot of people in this group do it, they've been very successful in figuring out what sort of the translational benefits of some of these things would be in sort of the field of healthcare. I think that's really quite the most important thing. And one of the areas I'm trying to right now dive into is how I could show patient care outcomes differences by using some of the techniques that I was using in assessment. And right, so that for me is sort of the next step. So I think that if you could somehow frame it in a way that, and especially because healthcare is becoming more familiar with patient-centered outcomes, I think some of this will open up even more, and as it becomes more and more accepted. But framing it in a way that is linked to an outcome for a patient, I think is really quite important and is really sort of key in terms of getting access to the healthcare system. And I think, I think healthcare systems, especially in the US, understand that in terms of opening up the door to allow for things to be done. One possible way Dr. Wong was talking about was, the idea of using previous frameworks. And I could, just like sitting here thinking about it, I'm just thinking about different ways that people frame end of life discussions or, key surgical discussions. Like, Gretchen Schwarzy here at the University of Wisconsin is a vascular surgeon who does a lot of work about how you could structure these high stakes communications, and maybe some of those already have data, and you could sort of see how ENA can pull some of the benefits of that out in sort of like a translational framework. But fascinating ideas.
I think that might be a good segue into our next topic of discussion, which is to sort of expand our ideas on those very concepts around quality improvement and how we can use patient-oriented, clinician-oriented participatory QE to improve the quality of care for individuals accessing healthcare systems. So if you would like to weigh in the chat, you're more than welcome to, on how you use quality improvement and QE in your own research, or if you would also like to offer up your comments through your mic, you can do that as well. But does anybody want to kick that off and sort of talk a little bit about quality improvement and the uses of QE for quality improvement in healthcare?
Sure, I'll kick off this one. I mean, I think this is something, honestly, that Kisu and I have been talking about and, struggling with a bit, right? Like, because when I think about, participatory QE and then this idea of use of QE for quality improvement, like they're definitely interrelated. But, and this is where I'm trying to figure out for me, like, what counts as participatory QE. So Abigail will definitely be coming later. And, what is involvement of participants, but maybe not, to the level that would qualify as participatory QE. So just to give an example, Kisu and I have done some work in partnership looking at trauma resuscitation teams and their communication practices. And like he was saying, one thing that he's really been trying to figure out and we've been talking about is, okay, how do we then translate that into actual improvements in trauma resuscitation team behavior that you can then link to better patient outcomes, right? And I mean, there's a few barriers around that. One is getting the data of the actual trauma resuscitations, and some issues around that, at least here, is that one, obviously trauma patients aren't coming in any sort of state to consent to being recorded for research. There are ways to deal with that, but that can vary by institution, and we've had some struggles with that here. But I think another one is trying to figure out, how do we feed back the data to our trauma teams in a way that is useful and actionable, right? So even if, and I think this is kind of a next step in this work, right? Like, so we could get data on what they're doing in the moment, we could code it, and feed it back to them and produce an ENA model. Like, how does that matter to them, right? Like, how do they use that information to then change their practice or increase things that they're doing that seem to be working well? And I mean, I think that's, that's something that we're thinking about, right? Because I think, when I think of research, like coming here to medicine and to surgery in particular, people care much more about the practicalities of it. They care much less about the theory and the model building, quite frankly, and they care much more about, okay, how do I take this and do something actionable to change my practice? So yeah, love to hear other folks' thoughts on that.
So I can just
go ahead.
Pop in, because I'm actually working in a very similar space, except for my focus is on care transitions and using QE techniques as a mechanism to actually develop a measure of quality. So if we think about quality improvement in healthcare, one of the things, at least from an engineer's, which I'm an engineer, perspective, is first we need to be able to measure quality so that we can decide if we're actually improving it. And if you go look at the literature around quality measurement in healthcare, there's different ways, right? So if you, like the classic one Donna Bedian describes, is systems-based measures, process-based measures, and outcome-based measures of quality. So if we can use a QE technique or multiple QE techniques to, say, analyze team communication in real time in a healthcare setting, we could actually use that as the foundation of a process-based measure of quality, right? And then rather than telling the clinicians, hey, I'm using this quantitative ethnography to make this model of your interactions, you can say, hey, here's an interesting different measure of quality that you might not have seen before, and here's how you can interpret it. So that's what we're actually doing. We're embedding it in a tool that we can then let the clinical team use to basically say, hey, that was a risky care transition, or, oh, that went pretty well, we don't need to follow up. So I think it goes back to that point I think it was Hitu made earlier. There's kind of two so what's when you're working in healthcare. There's the so what that the scientist cares about, like maybe it's advancing participatory QE, maybe it's studying team communication behaviors and adding to the theory in that world. But then there's the so what for healthcare providers, whether that's making trauma care more safe, making care transitions safer, anything like that. So I think it's really important to be able to answer both of those questions if you're a researcher working in this space. And the other thing that I'll add, which is probably a foreshadow to one of the later topics, if we can find ways to incorporate what we learn into the system of the healthcare workers so that they're not having to do extra work, like attend extra trainings or look at something that's not part of their workflow, it'll probably be more accepted and have a larger impact. So we have this, at least in the US, basically public health crisis of clinician burnout. So we really don't want to give them more work because then they'll get more burnt out and that would be even worse.
Yeah, I really like what you said, Abigail, because I think, we've heard it before, but the system is perfectly designed to produce the results that it does. And, if we don't adequately have tools in place to measure it, to better understand it, how can we truly implement any sort of measures of quality improvement to improve care? One of the things that's happening in Canada, and I'm not sure if it's the same elsewhere, I'd be curious to know what people think, but quality improvement is sort of a separate entity within the healthcare system that is run by people within the healthcare system. So it's not necessarily research driven per se, but it makes it really difficult for me as a health services researcher who's really interested in finding ways to innovate on existing solutions, because there are already people within, say, for example, my province's health authority, there's a whole team of people that are focused just on quality improvement, and they're detached from the research space. So they operate as a separate unit within the healthcare system, and we don't know what they're doing, and we often don't get to have those conversations as well. So it makes it really difficult to go in and ask certain questions and understand what's truly already happening, to sort of meet people where they're at. Does anyone else have any thoughts on?
I loved your comment. The system will perfectly do what it's designed to do, which in the United States is to generate bills, which is kind of a problem. Dr. Woolridge is totally right in that one of the problems is the data generation, where you get your data sets from, right? And so the way that quality improvement in the United States healthcare system works is by increasing usually the workload of the nurses and other ancillary support staff to add specific data points to some sort of database that a healthcare administrator is interested in, which is not really going to be the benefit of, quantitative ethnography or ENA. In my opinion, trying to figure out how we could sort of harness the big data that we already collect and find, some of the signals from that, I think will be the most important things. But it will require, I think the tough part about, quality improvement in healthcare, and, I really admire the work that Abigail is doing, is it's just really very hard. You have to sort of like rebuild the system from the ground up and design it to do something else in terms of sort of harnessing some of the data. So I think that's probably, to me, one of the key determinants of how this will succeed in the healthcare sort of field, will be how we figure out, where we could get the data, like where do we get the data, who puts in the data, what do we determine is important, and how can we define it for a healthcare administrator that this specific data will be important.
Yeah, and I'll just add one other piece to this is that it really depends on the quality you're trying to improve on some level, right? So if the thing that you, and this is back to both Jamie and Abby's earlier points, if the thing that you're trying to do is, shorten visit times, right? Like that's a very different goal from improving the quality of those interactions on some level. And those don't necessarily have to be incommensurate, right? And we know that more time is generally better, but it doesn't mean that like less time means less quality, absolutely. But the challenge is also that like, what is the thing that you're trying to improve? The thing you're trying to improve is the quality of an interaction. That's a lot harder to measure than the time of an interaction.
Mm-hmm.
You only need a clock to measure the time of an interaction. To measure the quality of an interaction requires a pretty sophisticated approaches, and yet there are things that that are required from those interactions, right? Like there are certain reimbursements that won't happen if something like shared decision making doesn't take place. Well, how do you measure something like shared decision making is a much more complicated question than how you measure the length of a clinical interaction, or whether things were logged in particular ways, or any number of other processes that might be much simpler to track. And I think this is getting sort of at Hisu's point about what healthcare administrators care about. And I think, at least from my perspective, that's a place where QE can really be impactful, is that, we really care about accurately measuring complex processes that involve, human interactions, right? And the more we care about those things, meaning we as a culture, and the healthcare system cares about things like patient-centered care and patient-centered outcomes and that sort of thing, like the more necessary it is for us to develop the kinds of measures that can look at much messier data, essentially, or much messier processes, and actually come up with measurements that can be useful either for care teams or providers to use as part of their ongoing work, or for systems, right, to think about systemic approaches that would actually change things. And I think that's where we're just starting to tap into the potential of an approach like QE, is in those areas where it really is hard to measure, and we don't really know the best way to do it, either theoretically or practically.
On a positive note, I think that there is a lot of potential still, right, in some of the data that's being start to be gathered. We're seeing a lot more video recording of interactions, a lot more data. Data between communication often passes through some sort of digital infrastructure. So there'll be opportunities for us to capture some of the things that happen around the things that Medicare might think is important, or Blue Cross Blue Shield will think is important, and we'll be able to better sort of sort some of that out more effectively. And I think a lot of the work that people are doing in automating some of this coding and taking some of the audio and dictating it automatically, all those things, I think maybe not today, but maybe 10, 15 years down the line will become a lot easier for us to make meaningful impact.
I mean, there's a lot of elements too, like Hisu was talking about, the critical thinking processes that happens within a physician or a clinician that doesn't really get talked about with an individual in a care appointment. The same could be said for care pathways and what determines what kind of care people receive. Something as simple as being labeled with an ICD-9 or 10 diagnostic code can really have a huge impact on how you are perceived as a person within the healthcare system, what kind of care you receive, how you are able to access that care or not access it at all. Simple things like, and I think we're seeing this in the time of COVID, especially individuals living with long COVID symptoms are having difficulty getting certain types of healthcare insurance or life insurance just because they've received that diagnosis as well. And so there's a lot of different behind the scenes things, billing claims. I'm sure it's just as messy in the US as it is in Canada, but why a clinician behaves the way they do, or refers a patient can often sometimes be influenced by how billings happens or claims happen. Mm-hmm. Does anyone else have any thoughts about quality improvement? I'm curious, Sylvie, what your thoughts are. I feel like the gears are turning in your head. You're just absorbing it all this morning.
Yeah, I'm laying back a little bit because just when I wanted to like say something about participatory QE and stuff, I got kicked off the internet, or the internet was gone, and suddenly everyone started to panic in this building. Anyway, what I was thinking about in terms of quality improvement was Kate. I'd love to invite her to speak a little bit about her project, because she's actually doing something that will have eventually, when she does have those results, they will have a huge impact on patients. Kate, you want to tell a little bit about your project? Sorry to put you on the stand here.
No problem. Yeah, I'm happy to. Forums were brought up earlier, and that's basically what I'm doing. I'm using Reddit to look at how patients experience side effects of antidepressants. So one really common thing that y'all might have heard of are brain zaps, which comes up all the time in forums. It's a really common side effect, both of antidepressants and antidepressant withdrawal. And I don't think a clinician is ever going to tell you, you might experience brain zaps as you go off this medication, right? But it comes up a lot and it's worrisome for people. And really interesting themes are emerging, actually. Subgroups of people where we know what side effects are really common, but I suspect, and the data is starting to maybe bear out, there are subsets of people that have specific clusters of side effects that maybe you could handle differently.
So eventually, Kate, sorry to continue asking you about this, but eventually, do you want to have some sort of recommendation package for clinicians? And if so, how do you imagine going from the QE study through the results to kind of thinking about how to implement those things in your recommendations?
Yeah, no, I appreciate the prompting. I think the thing that I keep coming back to is what I really want to know from the patient is what is hard for you, not what did the doctor tell you or what you think about that, but what are you not telling your doctor that would make your life better, basically. And if I can answer even a small bit of that question and feed it back to the clinician, I think that could be super beneficial. How exactly that would happen, I don't know. I think the natural point would be a paper or a training, which, as we had just discussed, is probably not super helpful for clinicians. I'm not very used to thinking about a clinician perspective, so this is pretty interesting to hear it from that side.
I think that would be, you know, looking at scientific method or platforms for communication are an effective method to communicate to clinicians. So I wouldn't discount that. And I think, you know, there's a drive now for evidence-based medicine and evidence-based care. So it's certainly a medium. It would be, you know, linking back to participatory QE, it would be really interesting to develop a study team or a cohort of people who struggle with mental illness and depend on antipsychotic medications and SSRIs and things like that, who would be willing to, you know, help interpret those findings and share that back to the clinical community as well, because I think that could be really powerful.
Yeah, I think that piece you just said about having it be more participatory is hopefully a good next step, because the catch-22 of doing things like Reddit is you're not allowed, at least on this forum, to interact with people. So nobody knows that I'm scraping their data. And technically it's public data, but it makes me feel a little weird and bad. And so I think taking it back to a group of actual humans offline and saying, does this resonate with you, would be a good step.
I think the other issue that this raises, which is an interesting one we haven't touched on yet, is the sort of blurry boundary between clinical medicine and public health, because I mean, it's particularly in the U.S., right? There's been a lot of sort of co-option of public health into clinical medicine, and Jamie, I don't know if that's true in Canada too, but yeah, I figured, but I think these are the kinds of places where that line gets a lot blurrier, right? Because there's, I mean, there's enough people on SSDIs and other sort of like, the kinds of medications that you're looking at, and the sort of epidemiological characteristics of what's going on sort of blend with the kind of clinical profile and clinical approach. And so those recommendations don't necessarily just have to be for clinicians on some level, right? That I think there's, aspects of public health that would be very interested in the kinds of, like in that particular case, the kind of work you're doing, but also like, I think there's a lot of cases where, this is getting back, Nancy, to your question too, right? Where like, we're really interested in how sort of large segments of people are dealing with, with particular health issues. We're sort of at that boundary between clinical medicine and public health, and so clinicians aren't necessarily our only target. This is also about health policy, and it's also about the ways in which we think about the sort of broader sort of population health or public health implications for aspects of clinical medicine.
Yeah, I think there's a lot of system level perspectives that are equally as important. And we're only just recognizing now the awesome power of person first care. In meeting people where they're at in an appointment. Recognizing that we're sort of closing on the hour, I think it would be a good idea to maybe move into our third topic. And so far, am I muted? I'm totally
you just
muted.
unmute for a minute.
Oh my goodness. Where did I lose you guys?
Just a few seconds.
Recognizing that we're at the sort of the hour is closing, we'll move to our third topic, but just to acknowledge, that so far we've really sort of dived a little bit deep into participatory QE and involving patients, but also clinicians in the research process, and how we can sort of better understand the healthcare system to be able to implement measures for improvement or quality improvement. And this sort of segues really nicely into our final topic, and it more focuses around health systems engineering as a whole. So how do we understand health systems? How are they built? How do people interact with them? And how can QE support health systems engineering to improve health outcomes for people who are accessing that? And I'll sort of default maybe to Dr. Wooldridge because she is our resident expert on health systems engineering. So maybe if you wanted to jumpstart that conversation.
Sure, I can try to do that. So one of the things that I keep hearing during this panel, and that I think is particularly important in this topic, is that to make healthcare better in any dimension, however you define that, we're going to have to involve people with different kinds of expertise, right? So we need clinicians. We probably need the people who are pursuing health, whether or not they're actually formally patients yet. We're going to need health systems engineers. We'll probably need some really expert methodologists, maybe from the QE community, and maybe some social workers, some public health experts. The list goes on. But in this world, this is actually kind of near and dear to my heart, because this is why I got involved in QE. I'm a systems engineer, and the framework I use that underpins all of my research is called the Systems Engineering Initiative for Patient Safety. And if you've never seen that model, the original one, actually, here we go. I have a handy dandy printout. So this one looks like a network, right? Like we see all these different elements that we can use to describe a system, and there's connections between them. And I was sitting in one of David's classes, and he showed me a network graph, and all I could think was, that's a way of actually looking at what the system looks like. So I bring this up because I think QE can be a really important tool and a big contributor to this area. But I think one thing that's really fundamental when we talk about how can QE support health systems engineering is to realize that there are other experts and frameworks like that one, or some other model that we need to draw on and leverage. So that's what I'm doing. I use QE as a way to visualize and explore different kinds of interactions within the healthcare system, and then close those feedback loops to give back to either healthcare administrators to say, hey, we really need to redesign this process, clinicians so that they can have that kind of real-time support to make their own decisions, or maybe even a patient.
The other thing, Abby, sorry, the other thing that sort of popped into my mind was people that don't interact with the healthcare system. Oftentimes, those are the individuals that I think would stand to benefit the most from being able to access healthcare, and in a lot of instances, they don't have the means or the same privileges as others who can access the healthcare system. And so oftentimes, we develop research studies that look at certain groups of people, not recognizing that within those groups of people, we are missing those who just forego care.
Yeah, so this is, I think, goes back to the idea of participatory kind of community-based action research. So rather than a researcher independently saying, hey, this is an important problem, talk to the people who actually are experiencing problems to find out what they need, right? So I have two colleagues who are healthcare systems engineers, who graduated from UW, Rupa Valdez and Rich Holden, who have been doing a lot of work around, they call it patient ergonomics. So in other words, what work are individuals doing in pursuit of health, whether or not they're in a formal healthcare setting. And Rupa in particular does a lot of work with communities of people who may not have access to traditional healthcare systems as part of redefining the system to improve that level of access. So great point.
And I just wanted to follow up on something else that you had said, Abby, which relates to a point Jamie had made earlier about this idea of closing the feedback loop. And I think, particularly as we're thinking about, well, how do we then engage in quality improvement? It can be sort of a black box. And so just case in point, I'm working with a resident on a project on nurse resident communication. And we, I think, have come up with some really important lessons that might help improve the system. But for a long time, we were like, okay, who do we bring this to that might be able to make actionable change? And turns out that another resident that she's friends with is on a committee that does the, and so we kind of made this informal connection, and now we know who we should talk to. But I think those things are not clear, at least at most institutions, right? Where do I bring these things I've learned to allow for actionable changes to take place? I did have one other thing too that I wanted to say, which maybe isn't completely related, but before it leaves my head, we've been talking about different challenges we face, and like Jamie had said, for example, in Canada, patient data seems to be much more off limits than it is here. But even here, to Hisu's point, you need to know how to get it and how to frame it in the right way. And I was just involved in, getting an institutional review board application approved for a project where we wanted to reach out to patients. Turns out that we needed to have a clinician partner in order to be able to reach out to patients, because they weren't going to let the researchers reach out to patients, but the clinician can do it as long as they're involved in their care, right? So there's all these little nuances of how you might even go about getting access to this data. And I wonder, as a group, as we're kind of developing our interest group in healthcare and how we can apply some of these methods, if there might be use in developing even some sort of shared repository of knowledge about these types of things, right? Okay, if you want to contact patients and get data, here are some barriers that you might face, but also here are some ways that you could potentially get around those barriers.
So we do have a few minutes left. Does anybody else want to share maybe their research or anything that they're doing within perspectives on healthcare systems specifically and how people access healthcare?
Potentially another question is, so the people who did come to this session and the people who were within the original panel, do we want to expand these interactions into like an official SIG? So it's not a symposium every year, but it's, you know, it has more of a structure. It, you know, we have events, or we have the repository, as Sarah suggested, or something that's more formalized in a way. Is
And
that something that, yeah?
Just to clarify too, we do have an official SIG. We just haven't done anything with it yet besides conference stuff, in part because getting the society set up and everything, like there wasn't really a framework yet. But I think just so people know, there is a SIG, you're welcome to join it. Membership doesn't confer any benefits yet, but I think this is sort of the thing that Sarah's raising, is that like as a SIG, we could do some things that would be really useful. And I really like this point, Sylvie, that like we could use some time to discuss like what are some of the things that we could do. Yeah, that's a good question, Penny. So if you want to join, you can basically contact me or anybody else, probably on this panel. But I think if you contact me, I'm trying to keep a list of people who are interested in healthcare topics. And I can also send out an email with everybody's email addresses so that you can, if you want to contact other people on this, yeah, I'll pop it in the chat in a second. You know, if you want to contact other people who are interested, I think that'd be great.
So maybe Jamie can wrap up the session for us, and then we can meet in the community chat in our breakout room to discuss the future. Does that sound okay?
Thanks, Sylvie. So we do have an additional 30 minutes, the community chat that's available, and I posted the link in the chat there for you. It's also in the Slack if you are in the Slack group. But I do want to thank our panelists for their very thoughtful insights and opinions and expertise around these subject areas, and also to thank all of you who showed interest and attended the session today. We certainly feel honored by your presence, of course. And yeah, we will continue the discussion in the community chat. So if you're interested or you have more burning questions, around the SIG or any other topics that we discussed today, we invite you to join us there.